which
I
is
am
important.
presenting, sir.
Go ahead.
Good evening, sir. My topic
Good.
is pH and its importance. Definition of pH is a hydrogen ion concentration in aqueous solution is expressed by pH, which means power of hydrogen and its logarithmic function of hydrogen ion. pH is equal to negative logarithmic of H plus ion. It is termed by Danish biochemist Søren Peter Sorensen in 1909. Normal pH value is 7.35 to 7.45. If pH is considered to be 7.4, H plus ion concentration would be 40 nano equivalent per liter. 1 nano equivalent equals to 1 millionth of the milli equivalent. A deviation in hydrogen ion concentration from normal range can result in alterations in protein structures, function, enzyme activity, and cellular function. Hydrogen ions are continuously produced by cell metabolism, like a hydrolysis of adenosine triphosphate, metabolism of glucose, and from carbon dioxide metabolism. So, some definitions to be learned is acid is a substance which increases high H plus concentration, that is a proton donor. Base is a substance which decreases H plus concentration, that is it's a proton acceptor. Buffer is a substance which reduces the change of pH in a solution when amounts of acid or base is added. Strong acids or bases are substances which are highly dissociable in a solution. Weak acid or bases is a partially dissociable in the solution. The intracellular functions which would be affected by pH is mainly the cellular metabolism, which includes enzyme activity, protein stability, cytoskeletal structure, muscular contractility, cell-cell coupling, membrane conductance, cell activation, growth and proliferation, cell volume regulation, and intracellular membrane flow. Coming to the different types of acid-base metabolism disorders. It is mainly classified as respiratory as well as metabolic. Respiratory includes mainly includes partial pressure of carbon dioxide. The normal PaCO2 is 40 millimeters mercury, which is approximately 5.3 kilopascals. In respiratory alkalosis, the PaCO2 is decreased due to hyperventilation, which is characterized by pH is more than 7.45, low PaCO2 and low bicarb. There is a thumb rule for change in bicarbonate in respiratory alkalosis, which is 0.2 into change in the PaCO2. The patient would be complaining of lightheadedness, visual disturbance, dizziness, etc., mainly due to vasoconstriction. The patient may also present with paresthesia and tetany. It is mainly due to hypocalcemia, which is due to the calcium is binding to albumin due to the increased available negative charge on the in the alkaline state. Another anesthesia related conditions resulting in respiratory alkalosis include anxiety in the pre-op stage. In the post-operatively, it is secondary to pain, full bladder or agitation. Other causes of hyperventilation includes CNS stimulation like fever, pain, thyrotoxicosis, hypoxemia, pneumonia in pulmonary edema, drugs which includes catecholamine, salicylate, and medroxyprogesterones. It also seen in sepsis and pregnancy, psychologically anxiety and fear. Respiratory acidosis increased in PaCO2 and it is mainly associated with respiratory failure. The problems are majorly classified as a central ventilator control, peripheral ventilator control, and VQ mismatch. The central ventilator control includes toxicity from anesthetic agents like benzodiazepine, opioids, stroke, spinal cord injury. Peripheral ventilators conditions such as myasthenia gravis, poliomyelitis, polymyopathy, neuromuscular blockade, and VQ mismatches may be associated with the pneumothorax, pleural effusion, atelectasis, pneumonia, and pulmonary edema. If PaCO2 that if increase in PaCO2 for every 10 millimeters of mercury, there would be increase in bicarb by 1 milli equivalents. 1 nano equivalent per liter increase in H plus ions increases pH by 0.001. Coming to the causes of metabolic acidosis, it is mainly based on anion gap. Anion gap is a difference between measured cations and anions. So if the anion gap includes potassium, the normal anion gap would be 14 to 16. If not included, 8 to 12. Based on anion gap, the metabolic acidosis are majorly classified as high anion gap, normal anion gap, and low anion gap. High anion gap includes ketoacidosis, lactic acidosis, uremia, toxins, salicylates. It majorly includes hypoxemia, hypoperfusion, and severe anemia. Normal anion gap includes loss of bicarbs from the GAT, mainly diarrhea, ileostomy, or urethral diversion. In the normal anion gap with the hypokalemia, mainly associated along with hypokalemia, renal loss of bicarbs will be seen in proximal tubular acidosis and carbonic anhydrates. Normokalemic and hyperkalemic includes renal tubular acidosis, uh, distal RTA, and hypoaldosteronism. And in a hyperkalemic condition include ammonium chloride toxicity. Decreased AG gap includes hypoalbuminemia and hypomagnesemia. And coming to the causes of metabolic alkalosis include loss of H plus ion in vomiting or by diuretics, increased reabsorption of bicarbs, hypokalemia, high PeCO2, and increased alkali pool in the renal impairment patient when we are administrating large quantities of ringer lactates. Coming to the mechanisms for regulation of H plus ion concentration, it is mainly by three systems, that is buffer system, which is local and immediate, ventilator, that is respiratory system, which is slower and it takes place within minutes, and renal responses, which is very slow and it takes hours to complete, but it may result in complete pH correction. Coming to the buffer systems, the various buffers include bicarbonate, carbonic acid, which are the main buffers in the extracellular fluid, interstitial, intracellular, as well as the bone. Hemoglobin and other proteins in intracellular fluids, along with the plasma proteins, constitute protein buffers. The phosphate buffers are in the intracellular and extracellular fluids and in the kidney. And bicarb is the major plasma buffer, and the phosphate is the major intracellular buffer. Bicarbonate buffer system, the main thing is these buffer system combines with the H plus and forms a carbonic acid, which can be degraded into water and carbon dioxide. The HCO3 bicarb is regulated by the kidneys, and the carbonic acid is regulated by the respiration. Coming to hemoglobin buffer, it helps in the respiratory regulation of pH. It transports a carbon dioxide from the tissue level and to the lungs for excretion majorly. It mainly depends on two effects, like Bohr effect and Haldane effect. In the tissue level, the RBCs takes up the carbon dioxide from the tissue from metabolism. It combines with water and forms carbonic acid. This carbonic acid divides into H plus and bicarb. This H plus has high affinity to the deoxyhemoglobin, which will be seen in the tissue level, and it combines with the hemoglobin and forms a HHB, and there would be O2 unloading also there. And these HHB comes to the lungs, and when it comes to the lungs, it gets the O2 will be replaced by H plus, and there would be oxyhemoglobin along with H plus. This H plus combines with bicarb, and this bicarb is again forming carbonic acid, dividing into water and carbon dioxide, which is then excreted. Phosphate buffer system is the main intracellular buffer system. Sodium diphosphate combines with H plus ions and forms sodium, and gives us a sodium and eliminated as phosphate. It plays a major role in renal tubular fluid and intracellular fluid buffering system. The respiratory mechanism is mainly due to when the patient is acidotic, the patient tends to hyperventilate to excrete all carbon dioxide to the respiration. When the patient is alkalosis, they would be hypoventilate to restore all the carbon dioxide. When the CO2 is high, it combines with water, and again it's forming carbonic acid. This H plus ion is an stimulator for respiratory system in the medulla. It will increases the rate as well as depth of respiration. thus forming a hyperventilation, and carbon dioxide is eliminated and pH is normalizes. This doesn't give, this is just transient. It can't correct the acidosis completely when it is very severe. Coming to the renal mechanism, the main aim of the renal system is the excretion of H plus ion, reabsorption of bicarbonates, and the excretion of ammonium ions. It takes place in different levels of the nephrons, in proximal convoluted tubules, in the loops, and in the tubular cells. In the proximal convolute, in all these things, all these process will take place. That is excretion of H plus ion, and there will be reabsorption of bicarbonate ion. In proximal convoluted tube, the same thing. Water combines with carbon dioxide, forming carbonic acid, which again divides into H plus and bicarbonate. H plus would be excreted for this. So one sodium ion comes inside, and this bicarbonates get into the plasma. In the tubular cells, there would be sodium bicarbonate, which again the sodium comes into the tubular fluid, and then it's reabsorbed in the plasma. This bicarbonate combines with the H plus, which is excreted in the tubules, which forming carbonic acid, and which again gets divided into carbon dioxide and water. There would be again phosphate buffer acting in the tubular level, and the H plus is again excreted. Ammonium is also combines with the H plus, which is given out into the tubules, and it combines to form ammonium, and then it's excreted. Thank you.
Hello, sir. Sorry for interrupting, sir. I'm on duty today. I got an emergency, sir.
Yeah, I can go. No problem.
Yes, sir. Thank you.
Completed, sir.
You complete. You finished?
Yes, sir.
Oh, okay. Now you said the Danish chemist Sorensen found out or formulated the word pH. And
Yes, sir.
why did he find it out? What is the purpose of it? What did he achieve by proposing a concept called pH? He's basically only a chemist, not a doctor, not a medical person, isn't it?
Yes, sir.
So what did he want to prove by formulating this concept of pH? In chemistry, what is the neutral number between acid and alkali?
It's 7, sir.
7. Okay. So anything above 7 is called alkaline.
Yes,
anything
sir.
below 7 is called
Acidic.
Okay, that is the reason why we proposed this. Now, what is the normal pH of blood? You said
7.35 to 7.45.
7.35 to 7.4. Is it alkaline or acidic?
It's alkaline, sir.
It's alkaline. Why blood is slightly alkaline instead of not being just exactly 7? Why nature has made that the pH should be 7.35 to 7.45, not exactly at a neutral pH of 7? Anybody else who know that? Sri, are you there?
Yes, sir. No, sir, I don't know the answer.
Arvind? Anish Kumar, you are interested in physiology. Do you know the answer? Are you there, Anish Kumar? Kalpana, L.
Yes, sir. Sir,
Right, okay.
enzymes needed as alkaline with alkaline environment to act. So I think, sir, don't know exactly.
That's a best answer. The
Yes,
correct answer is life is an acidogenic process. That is, more number of hydrogen ions are produced in our day-to-day metabolic activity. So if your blood is in the neutral range, exactly 7, you will easily drift into acidosis all the time. So to manage the excessive number of hydrogen ions that are produced, body requires a slightly alkaline medium so that it can nullify the hydrogen ions that are produced. Okay? So if you see the old Wiley Churchill Davidson book, which deals on acid-base balance, the first line in the chapter is life is an acidogenic process, which means it constantly produces more hydrogen ions, which will make your blood more acidic compared to the other activities. So if your pH is on the exact neutral of 7, you will always be on an acidotic state, which is not compatible with life. And that is the reason why our blood is always on the slightly alkaline side of 7.35 to 7.45, with an average being 7.4 as being given. Okay? And how is this pH measured? When you talk about pH, you have to know how it is being calculated or measured in our blood. How do you get your pH value? Have you worked in ICU, Bindu?
Yes, sir. Arterial blood gas analysis.
You have to do an arterial blood gas analysis. Okay? So that blood gas analysis machine, how does it measure the pH? It measures using what is called a pH electrode. Okay? So there is an electrode where the blood you take sample you take is being fed into that machine. So it will know the gradient of your hydrogen ion concentration in the blood, and it will react to produce an electrical gradient by which you can measure the difference between the buffer that is present in the electrode solution as well as the sample that you feed into that. And this pH electrode is used to measure the pH. Okay? And then based on that, you say whether the patient is in the normal pH range or whether he is in an acidotic state or an alkalotic state. And the maintenance of pH is done by the three mechanisms. You said about the buffer mechanism, respiratory mechanism, and renal mechanisms. Buffer mechanisms come in immediately because body wants to maintain the pH in this particular range all the time for the effective functioning of all the systems. So buffer systems are the immediate response to any alteration in the pH range when it becomes acidotic or alkalotic. Mostly it will tackle or try to prevent the acidosis rather than alkalosis. And the slightly later response will come from the respiratory system. And the most valuable or easily manageable thing is the elimination or retention of carbon dioxide. So whenever there is a metabolic acidosis and there is lot of hydrogen ions cooling up in the body, the carbon dioxide, which when it combines with water forms another weak acid called carbonic acid. If you wash out that carbon dioxide, then the formation of carbonic acid and thereby the production of hydrogen ions will be decreased. So the compensatory effect for metabolic acidosis will always come in the form of hyperventilation to wash out the carbon dioxide. On the contrary, if your blood is more alkalotic, with more retention of bicarb, less hydrogen ion, then body will try to retain the carbon dioxide and break down the carbonic acid formed and retain more hydrogen ions and excrete more bicarbonate in the urine and try to rectify the alkalotic situation. So this is the second response that the second mechanism that will help in maintaining the pH. And the third mechanism is by the renal mechanism, which comes on later. More than 24 to 48 hours it will take to come into play when the patient is chronically acidotic or alkalotic. And the main mechanism is to conserve bicarb as much as possible. As I said, always the chances of developing acidosis are much, much higher than developing alkalosis, whether it is respiratory or metabolic. So the body will always try to conserve or retain bicarbonate so that we can prevent acidosis or excessive hydrogen ion accumulation. Okay. So that is the first mechanism. Second is whatever excess hydrogen is there, that will be excreted. And third is the excretion of weak acids. And fourth is the excretion of ammonia, which is also going to contribute to the change in the pH. These are the four mechanisms that renal system will try to do when there is an alteration in the pH. Now, what is Stewart hypothesis of pH? You have to mention that also in your answer if pH is asked. Any idea about that, Bindu? Stewart hypothesis or strong ion difference hypothesis. Have you heard of that?
No, sir.
No. Anish Kumar? Kumar is not there, I think. He's not answering. Okay. So, right. I'll just show my slides to you to